Welcome everyone back from our break, and allow me to introduce myself. My name is Brian McAlpine. I'm going to be speaking a little bit here about some of the heightened maternal mortality rates and how they intersect with race in the United States. In a little bit, I'll get to some new data that just came out today, a piece right in the New York Times, but as I said, we'll get to that more. I wanted to give a big thank you to Dr. Amy Pollock. She is the Director of Maternal, Newborn, and Child Health at the Gates Foundation and one of our distinguished guests this weekend. We'll start with a bit of a case study here. The woman that you see is Shalon Irving. She was a CDC epidemiologist. Pictured here, she's 36 years old. One of her interests at the CDC was working to eradicate health disparities, especially among minority communities. And despite having a strong family support and a relatively healthy lifestyle, she passed away, despite multiple emergency care visits during the postpartum period. She passed away 3 weeks after giving birth, which left her daughter, pictured here, to be taken care of by her mother. So moving away from that kind of tragic case study, why is that important in a larger context of maternal mortality in the United States? Black expectant and new mothers in the US die at about the same rate as women in countries like Mexico and Uzbekistan have very poor health outcomes compared with some of the more developed countries. This is some data from the World Health Organization. I believe that reducing the shameful gap between maternal mortality along racial lines should be a major focus on public health. Now, as I had indicated at the top, some data that just came out today from the National Center for Health Statistics and a headline that ran in the New York Times saying maternal deaths rose during the first year of the pandemic. The report found that the rate of maternal mortality rose 14% from 2019 to 2020. And one of the most startling figures that I pulled out of this article was that Black women in America experienced the most deaths. 1/3 of the pregnant women and new mothers who died in 2020 were Black, though Black Americans make up just over 13% of the population. Pictured, we have a gentleman discussing his wife in some testimony given to Congress on maternal mortality rates. So we can talk about some contributing factors within determinants of social determinants of health. We can talk about structural inequalities that exist within minority communities. Things like access to healthcare, insurance, transportation, unconscious bias in the medical system, things like education, which would lead us to our problem statement. Our problem statement on this matter is, because of issues relating to racism, structural inequality, and other systemic disparities inherent to healthcare in the United States, Black women are significantly more likely to die following pregnancy compared to other demographics. So working from an individual level through all the way out to the policy level using the socio-ecological model, we're just going to run through, because I am a little short on time today, just going to run through some factors that help and hinder at all of those levels in regard to our problem statement. So at the individual level, things that affect maternal mortality, we've got health conscious behavior, lifestyle, regular exercise, a healthy diet. But as we saw in our case study, even though Shalon adhered to those sort of practices, she still fell victim, to being a statistic of maternal mortality. Hindrances would be things such as pre-existing conditions, chronic health issues, comorbidities such as hypertension, diabetes, obesity. Now, at the interpersonal level, we see help with a support structure, family, friends, people that can help with childcare and the postpartum recovery period. And in terms of hindrances, we've got lack of postpartum support. right? So access to mental health, people that can maybe transport you around, those sort of things. At an organizational level, paid maternal leave is a big help to reducing maternal mortality. Whereas on the flip side of that, we've got lack of employer-based health plans as a hindrance. At the community level, access to quality prenatal and postpartum health care is a big help to reducing maternal mortality. And things like healthcare deserts and lack of access to health clinics within a community are a hindrance to that. And finally, moving out to the policy level, one thing that can help reduce maternal mortality rates are automatic enrollment into insurance plans and coverage for women that are in that period of antenatal health care. And then a big hindrance on the policy level is some of the newer restrictive abortion bans that we've seen in Texas. I believe there's a new one being proposed in legislature in Florida. Things that basically restrict reproductive health services. All right, moving on a little bit here, we want to talk about solutions, evidence-based solutions. I'm going to talk about three very distinct geographic regions. Two are in the United States and one outside of the United States, but I believe it has applications that could be transferred here. One is a partnership among multiple stakeholders. Number two, we've got an interconnected network among collaborators, social workers, providers, care managers. Care managers is the big one in this one. And finally, number three is a community-based health education intervention to low and middle income countries. They also distributed care packages to new moms and their babies with things like diapers and other supplies that new mothers would need. And we'll look at how effective some of those programs were. So in the Ohio intervention, as I said, it was a community-based intervention. And what they did was try to create a network of perinatal health doctors, nurses, policymakers that would work to try to bring more full-term births. Looking at North Carolina, the second of the three interventions, this program also sought to create a network that would bring together regional providers. And this introduced, as I said, the medical home model. Pregnant women were teamed with a care manager throughout the course of their pregnancy to help them with things like managing appointments and such. And finally, we've got, as I said, the low and middle income country intervention where supplies were given directly to moms, and there was a widespread information campaign in those areas. How would we measure successful intervention? Well, in Ohio, we could look at if a larger number of women were bringing their births to full term. In North Carolina, specifically, we would see how many women who were eligible became enrolled in this program. And with the low and middle income country interventions, we could look at how many care packages exactly were distributed. Some barriers to some of our interventions. We've got things like community buy-in, skepticism, historical distrust of the medical establishment. And then some solutions would be to really engage stakeholders and community leaders, create an open dialogue, and be sure to be very transparent when implementing our health promotion. And finally here we've got a logic model to look at. Some things of note, we've got outcomes that look at a 2-year period. We want to see more full-term pregnancies, 20% increase. And then in our impact column over here, looking at a 1 to 2 year period, we'd like to see reduced maternal mortality of about 10 to 20%. I'd like to thank again everyone for joining me for this brief presentation. I know we had to run through some of the slides quickly. I will post the PowerPoint if anyone wants to view it a little more slowly, and also to check out the references. If you have any questions, feel free to reach out to me, and I thank you all very much.